Good morning, ladies and gentlemen. And in welcoming you, I'd like to acknowledge the traditional owners of the land, the Gadigal people of the Eora Nation, and pay my respects to their elders past, present and future. This time yesterday, I was on a teleconference to the head of agriculture in the World Bank in Washington. And we were talking about the grand challenges in agriculture and science more generally, but particularly agriculture. And I said, what's the biggest in agriculture? And he said nutrition. He said it's how we produce food that actually provides nutrition. And I reflected that it was a particularly, it's probably not what you'd have heard even 10, 15 years ago. And similarly, 10, 15 years ago, we didn't think of nutrition and the shadow side of it, obesity, or the other side, starvation, to the level of a major scientific study. It was going on, but we didn't realise just how important it was. And we didn't realise, too, how this area was becoming an area of enormous research and clinical strength in Sydney. And one of the great leaders of that area is Louise Baur. And we're really lucky to have Louise addressing us today. And she's, as you can see from the sheet, the Professor of Child and Adolescent Health and Associate Dean and Head of the Children's Hospital at Westmead Clinical School at the University of Sydney. She's loads of other things too, one of those, really brick-like CVs, but an enormous contributor on many, many boards and committees, but a great leader in research on obesity in children and adolescents, not only how it happens and causes and early signs, but what we do about it. And as such, it's one of the most important problems to address in our community. And so we're lucky to have her, and we're thrilled to have so many colleagues from the health area here today. Some of you I know have been coming to these seminars, but some are new, so welcome. And hope you'll think about coming to the others, but today is particularly exciting. So with that, let me invite Louise to address us. Thank you.
Thank you, Mary. Thank you for the privilege of being able to come here and talk with you. As I start, I too would like to acknowledge the traditional owners of this amazing land in which we meet, the Gadigal people of the Eora Nation, and recognise their long, long tradition of learning, of inquiry and of care. I also want to acknowledge that the work I'm talking about today is the work of many, many, many collaborators, the University of Sydney, the Children's Hospital at Westmead, other parts of Australia and beyond, and this is not the work of one person, this is work of many people. So, I want you to think, how would you respond to a disease with the following characteristics? It's affecting increasing numbers of people, mainly adults, but increasing numbers of children. It's associated with a decreased quality of life and shortened life expectancy. There's a strong genetic predisposition. It's globally prevalent. There's a large economic burden to it. It contributes to death for a whole range of other diseases, and most health professionals are very poorly trained in it. You'd rightly be incredibly concerned. Action stations, we need to deal with this issue. But what about this one? A disease with a strong genetic predisposition, but that's mainly manifest in a given environment. It's highly stigmatised. It's not perceived as a disease, indeed, by much of the medical profession or the community. It's the subject of media voyeurism and victim blaming, and affected individuals are seen as less attractive, morally weak, morally vulnerable, weak-willed, and bringing the disease on themselves. Well, welcome to the issue of obesity. This is still an issue. The World Health Organization describes obesity as one of today's most blatantly visible yet most neglected public health problems, and goes on to describe an escalating global epidemic of overweight and obesity that is taking over many parts of the world. Still others have described it as the millennium disease. Now, these are strong and emotive words, but are they correct? I want to talk today about how big a problem really is obesity in children and adolescents, touch briefly on whether it can at all be treated, and look at whether obesity in early childhood can be prevented. And in so doing, I'm going to be looking at epidemiological data linkage and cohort studies, at treatment trials and systematic reviews, and of health promotion interventions. So let's have a look at, well, just really how big a problem is obesity in children and young people. How do we measure it? Well, we look at body mass index, BMI. I bet many of you know that term because it gets bandied around a lot. And that's weight over height squared. And through a whole range of different studies using sophisticated body composition techniques, we know that it's a reasonable measure of body fatness in populations and clinically, but it needs to be adjusted for age and sex. You can see here a BMI for age chart, so BMI on the y-axis, on the vertical axis, and age on the x-axis, and you can see it going from 2 to 18, and you can see BMI isn't sort of static. In fact, you can think of 2-year-olds sort of plump and, toddlers who are sort of round for their height, and then at the time of school entry, children at their lowest weight for their height, and then of course BMI increases apparently inexorably into adulthood, and we need to adjust for this in looking at this. But we're also interested in where the fat distribution is, and so we look at things, simple measures such as waist to height ratio. My colleague Sarah Garnett and others at the Kids Hospital at Westmead were among the first to start using this and to document its utility in looking at clinical and populations of people. So basically, if your waist is more than half your height, you're at increased risk for diabetes and heart disease. It's on a continuum, of course. And that's the case whether you're 6 or whether you're 86. And so we use this in actually looking at populations. So let's go and look at what we've found looking at populations. I'm going to be presenting data largely from that work that Sarah Garnett has done, analysing existing population surveys. These were done in Australia from 1985 through to 2014, so essentially a 30-year period where school-aged children had their heights and weights measured. Was nationally representative. These weren't unusually self-picked children. We can see overweight in blue, and the red is obesity. And in 1985, when I was a trainee learning to be a paediatrician, a young doctor learning to be a paediatrician, about 12% of children in Australia had overweight or obesity. But over the subsequent 10 years, through to the mid-1990s, we saw this dramatic rise, almost a doubling of overweight and obesity over that period of time. While the studies were being done, it sort of took us by surprise. We didn't really know it was happening. No one was talking about it. Certainly no one was training people like me in the 1980s or early 1990s about this issue. What we've seen, that there's been an apparent plateauing in prevalence over the past 10 years. So currently about 1 in 4 school-aged children are affected by overweight and obesity. And you can see that the number who have obesity itself, the more severe end, is actually increased. But over time, it's not just that we're seeing more young people with obesity. Those who have obesity have more severe obesity. So again, we looked at some of these data, and we looked at those who had a measure of severe obesity or morbid obesity, so equivalent in an adult to a BMI more than 35. And that's the green bit of the columns that you can see. And you can see that over this period of time, morbid obesity, I hate that term, increased in prevalence. And essentially, of those school-aged children who had obesity, more now have severe obesity, about a third of them, compared with in the distant past. And that has lots of implications for clinical treatment and for service delivery. Now, we sort of had an idea this was happening, but we didn't absolutely know it until we did the epidemiological studies, because we've been seeing these patients coming into the health system. But I'll come into that later. it's not just more severe obesity. The obesity where the body fatness is has changed too. We're seeing more children with what we call central obesity, abdominal obesity, which is associated with increased risk for diabetes and heart disease. So we use that friend, waist to height ratio, and guess what? It's gone up. It hasn't even started to plateau over that period of time. So the fat distribution itself is changing. We are seeing more children with central obesity, and we shouldn't be surprised then that we're starting to see children with type 2 diabetes or with a whole range of cardiovascular risk factors. Now, so I'm hoping you're saying, yes, this is real, it is actually happening. But epidemiology has also highlighted that we're seeing social disparities in obesity, as we are also seeing in adults with a whole range of non-communicable diseases. Now we're seeing social disparity in obesity amongst children. So here are data from the National Secondary Schools Diet and Activity Survey, with which I was involved, which is an across Australia analysis of high school students. And we knew their postcode of where they lived, so that gives us a measure of socioeconomic position. And you can see that we divided them into threes: the high, the medium and the low socioeconomic position young people. And guess what? The odds of having overweight or obesity were dramatically increased if you lived in a region that was seen as having a low, more socially disadvantaged. So basically, youth of lower socioeconomic position were 1.6 times more likely to be affected by overweight and obesity than those of healthy weight. So we're seeing this social disparity very clearly. Now, if that were not bad enough, the next slide I'm going to tell you just highlights that it's actually worsening. These are data from my colleague, Dr. Louise Hardy, at the University of Sydney. She has led some of the analyses of the New South Wales Schools Physical Activity and Nutrition Survey, which has been done over a number of years in school-aged children in this state. And again, they too looked at postcode, and they divided the children into low socioeconomic status areas, middle and high. And you can see here that there was, in 2004, a difference. There were more children with obesity who came from more socially disadvantaged areas. But look what's happened at the 2015 data. We see this dramatic increase in obesity in those in more socially disadvantaged areas. We're essentially seeing a widening social disparity that's occurring. This is growing, and that's of great concern. So you say, well, that's Australia. What a challenge we have. What's happening at a global level? My colleagues at the World Obesity Federation have put together data from around the world to look at the prevalence of overweight and obesity. These are data just for boys, and you can look, basically, the hotter the colour, the higher the prevalence of overweight and obesity. The cooler the colour, the lower. Now, I can show you that over in the right-hand bottom corner in the Asia-Oceania region, New Zealand leads the pack, followed by Taiwan and Singapore. Mind you, Australia, I think, is number 4 there, but you can see it's affecting our region very much. Can I just point out that India and China don't have a blue colour? They've actually got increasing prevalence of overweight and obesity amongst school-aged children. And indeed, in urban areas, they've got prevalence rates that are equivalent to what we're seeing here in Australia, particularly amongst boys. I just want to point out to you that the Middle East have very, very high prevalence rates. Kuwait, Qatar, UAE, over 35%. The lower part of Europe, profoundly affected by this, and of course both South America and North America really dealing with this significant health issue. So it's not just an issue in high-income countries. Low and middle-income countries are also confronted by this. Profound concerns about what the long-term implications will be. So what are the health consequences? We know it's prevalent. Does it cause health problems? In this picture here, you see a DEXA scan, dual energy X-ray absorptiometry scan of a young person with obesity. And it's really there to say that essentially all body systems can be affected by obesity, particularly if you have severe obesity, and particularly the older you are. So we certainly at the Kids Hospital see young people with obstructive sleep apnea, with a whole range of endocrine disorders, with fatty liver disease, gastroesophageal reflux, with raised blood pressure, and with a whole heap of orthopaedic problems and more. In the early 2000s, my colleagues and I, led by Sarah Garnett and including some of the people here in this audience, were involved in following up a group of young people who had been born at Nepean Hospital in the 1989-1990. And when they were 15, we went and measured them, we took their blood pressure, and we took some blood from them, and we looked at risk factors for heart disease and diabetes. So we measured triglycerides and cholesterol and insulin and looked at their blood pressure. And we looked at how many of them had 1 or 2 or 3 or 4 or more of these risk factors. And we looked at their body mass index as well. And what did we find? Well, essentially, the increasing body fatness, increasing BMI was associated with increasing number of risk factors. Now, these were like high school students. They weren't patients at a hospital. They were just happened to be born in Western Sydney. They were a random group of young people. And essentially, by age 15, over 1 in 10 of them had 3 or more risk factors for heart disease or diabetes. I think if we did that nowadays, it would be even higher. So this is what's confronting us. Now, it's not just risk factors for future disease. If you work at a place like the Children's Hospital at Westmead, where I do, you're seeing these young people already presenting with health problems. So we are seeing more young people with obstructive sleep apnea requiring, for example, CPAP therapy. The rise in obstructive sleep apnea treatment and CPAP treatment is largely driven by the obesity epidemic, not just in adults but also in children. What you're looking at in this slide is the underarm or axilla of a person in its darkened, thickened, pigmented skin. We call that acanthosis nigricans, and it's a skin marker of insulin resistance and prediabetes. We see lots of these young people. Even the psychologists and dietitians with whom I work recognise this all the time. It's not an obscure medical diagnosis. This is something you see. And we are also seeing children with lots of significant orthopaedic problems. So this is an X-ray of the pelvis, and essentially we get children with severe obesity can end up having the slippage of their femur at the epiphysis or growth plate at the head of the femur, and that needs to be pinned. And what you're seeing there is a pin on the left side of the femur, on the left side. We're getting more of these people coming to the hospital. We don't have necessarily the best measures of the impact of these for a whole lot of reasons, but we are certainly seeing those, and services such as Sleep Unit have had to really expand the types of services they do in order to deal with these. We now also see people with type 2 diabetes, which we never saw before. These clinical problems are much more likely if you have severe obesity or central obesity. And what did I show you before? We've got a rising prevalence of severe obesity and central obesity. So you don't have to think too hard to realise what the implications for that might be. But it's not just these older kids who are having the problems. Even young children, like 2 to 4-year-olds with obesity, are more likely to be hospitalised than their age peers who are of healthy weight. Now, Alison Hayes, my colleague at the University of Sydney, health economist, recently published this work, which was the first in the world to show this problem. So it's a data linkage study, a follow-up of young children from the Healthy Beginnings trial, which I'll tell you about later. And she asked the question, well, does weight status affect healthcare costs? What we'd done was actually look at all, what medicines these kids had used, hospitalisations, emergency care use, GP use, and so on. And we're showing, I can show you these things here. So you have on the left-hand side healthy weight kids, the overweight kids in the middle, and the kids with obesity on the right-hand side. And What we're looking at is the mean healthcare costs over the 3-year period. They're 2 to 4.9 years of age, okay? You wouldn't expect large healthcare costs. But the children with obesity essentially have 1.6 times the healthcare costs of those who don't have obesity. And in fact, they're 2.6 times more likely to have been hospitalised over that period of time for things like ear, nose and throat and respiratory problems, which we know are complications. It's probably obstructive sleep apnea, things like that. Now, this is the first study internationally to show that these issues are happening even before kids reach school age. The implications long term, big question mark, but we can only be concerned about this. So it's definitely a prevalent problem and there are health consequences. Don't let anybody say that this is not the case. So what do we do with this? Now, in the early 2000s, my colleagues, the World Obesity Federation and I, were getting really het up about this issue. And so, in order, as a form of therapy, we decided to write a large report to the World Health Organization about this. And we involved people from around the world collecting data about just how significant this issue was. We published this report as well. And there was a degree of flurry of activity for a period of time at WHO around this, and then nothing, essentially for 10 years until the then Director General of WHO, Dr. Margaret Chan, established the Ending Childhood Obesity Commission, seen as and from her point of view, because this was now affecting children in lower middle income countries. It wasn't just an issue in high income countries. So this data I've presented here and other data were used to really drive the need for this issue, and a report came out with a whole range of recommendations which I'll show you, and I was involved in one of the working groups for this. The report highlighted that childhood obesity poses an urgent and serious challenge, which is that sort of measured WHO language to highlight that this is really a concern and we need to do something about it. Hey, you member nations. And in this infographic, we can see the 6 main recommendations they made. My comment would be that they were perhaps not upstream enough, and we can talk about that later. But I want to pick up on 2 of these recommendations here. And the first one is that of weight management. Children and young people affected by obesity actually need treatment. We can't just try to prevent it, important as that is, and I'll come back to that later. So can it really be treated? What's the evidence for treatment? People ask me that all the time. Well, there have been many different studies, internationally and in Australia, and just 4 of the studies with which I've been involved, which happen to have really great logos, are actually shown there. And you can see there's an enormous great issue to do with acronyms as well. Live, Eat and Play, the Parenting, Eating and Activity for Child Health Study. The one I think that's the best was the Hunter Illawarra Kids Challenge Using Parent Support Hiccups. Now, these were all NHMRC funded studies, and they've all had, and I'll address different issues, and there have been a range of other studies that my colleagues at the Children's Hospital at Westmead and I and elsewhere have been involved in. They've been in a range of settings, community, hospital clinics, they've been group interventions, individual interventions, different levels of severity, drug therapy, behavioural therapy, different levels of intensity in different age groups. There's an enormous amount of information, some of it very good, some of it not so good. And the issue is, how do you make sense of hundreds of studies? How do you know what to go and do? And it's in that context that I was introduced through other colleagues to the concepts of very rigorous systematic reviews. Internationally, there is a collaboration called the Cochrane Collaboration, which allows people who are interested in high-quality evidence to come together in a rigorous way to look at existing published evidence and work out what is the high-quality work versus the less quality work, and see if by combining studies from a range of different ways in a thoughtful, systematic way that you can learn more about what is happening. So with colleagues, in 2009, we published this quite detailed Cochrane review on interventions for treating obesity in children and adolescents, and showed indeed that family-based lifestyle interventions with a behavioural program can lead to decreases in overweight in both children and adolescents compared to essentially standard care or not giving any treatment. And subsequently, a wonderful PhD student of mine, Mandy Ho, now in Hong Kong, undertook a quite further detailed systematic review looking specifically at whether you get outcomes also around cardiometabolic outcomes. And indeed, there was improvements in cholesterol, in triglycerides, so blood fats, and insulin, so measures of pre-diabetes. So this was very encouraging. When you work clinically, you think you know that this can work, but it's much better to have a very systematic approach to this and to actually undertake studies to work out if what you're doing makes a difference. Now, that Cochrane review in 2009, because the evidence has expanded, has now become 6 updates, 6 separate reviews that have been published very recently, and the data still hold, although there are still big challenges and many research questions that remain unanswered. And those are very important issues. Now, I want to now just highlight 2 particular studies that we've done at the Children's Hospital at Westmead that raise interesting issues, and they haven't been incorporated in the studies that I've just shown you because of their study design, or because they're actually not looking at a no treatment control. So this data is in about 110 young people, and we looked at 2 different types of dietary intervention in adolescents. Now, many of you will have heard about, an increased protein diet, or should it be just the high carbohydrate, low energy diet? There's been that debate, which one's going to be better? And we looked at that. We had very intense and good support from paediatric dietitians to these young people, really supported them in a high quality way. And what did we find? Well, you can see here, these are each of the results for the different patients as shown here. This is these data here are for 6 months. And what did we find? Huge inter-individual variation. Some people lost a huge amount of weight, and some gained some weight. And it didn't seem to matter whether you were in the high protein diet or the high carbohydrate diet. We had good outcomes for some in both, and poor outcomes for a smaller number in both as well. This raises all sorts of questions. Well, which diet, which approach might suit which individual best? We're still trying to find that out. One of the lovely things that our dietitians do is actually work with individuals and offer them a range of strategies to help. So this is part of the discussion, empowering families and children and young people to think through what approaches would work best for them. It still remains a big challenge, as you would know. This is actually another form of that, showing that there was no difference between these. This is looking at the weight status over that period of time. And yes, there was weight loss at 3 months, and there was loss again at 6 months, but there was no difference between them. Interestingly, we all thought that the increased protein diet was the preferred one, but in fact we found no difference between them. We still think it's a better quality diet, and that's the one that we use as our main type of dietary intervention. So let me show you another study now, one that's just been published earlier this year by another wonderful dietitian at our hospital, Megan Gow, who looked at young people with obesity who also had type 2 diabetes. So this is a before and after study here. And she took these young people. This is a dreadful disease to have in childhood or adolescence. It's still uncommon. And instead of just treating with medication, which is really important, we decided to give them very intense dietary support and quite intense support, and to use a very low energy diet, so using shakes and bars to help that. You'd say, oh my goodness, I thought that was just the Biggest Losers. I didn't realise that you'd use it in children and young people. We don't use it with everybody, but these young people had very severe obesity. They already had a very significant life-threatening complication in early life. And so they were given a very structured diet with the support of a highly experienced dietitian. And what we can see, in the black bars, we look at outcomes at 8 weeks, and 6 months later, the data in the white bars, is that a number of these young people lost quite a significant amount of weight, 7 to 11 kilograms over a 2-month period. There were some who found it hard to adhere to that, and they had very little weight loss. On the left-hand side, those who did have that weight loss, what was interesting is that a number of those had their diabetes essentially disappear. They came off treatment for their diabetes. Their liver fat decreased. Profound changes in their metabolism and in their health at that period of time. This is the first study to look at this type of dietary intervention in young people with diabetes internationally. And we think it should actually help change the normal approach to dietary intervention in newly diagnosed young people with type 2 diabetes. So I just highlight that there's really interesting evidence coming out, and that actually undertaking research in clinical environments and asking research questions can be profoundly exciting. But there are challenges in translating this. Let me show you just one example of this. In the Beach data set, looking at GPs, where this amazing data set over many years looked at 1,000 GPs each year and asked them to keep information on 100 consecutive patients. And we were able to go with Michelle Creticos, who's now in the New South Wales Ministry of Health, to look at these data and work with the Beach team. And what you see here is 200 faces. So in Australia, of every 200 children aged 2 to 18 who go to their GP for whatever reason, 60, that's 30%, have overweight or obesity. You're thinking, well, that's a bit higher than the average, what you told me about before. Yes, it's higher. And guess what? 23 have obesity, 11.5%. Oh my goodness, that's high. And then we asked, well, what are they being treated for? Well, only one is offered anything that looks at all like weight management. And there are a lot of barriers when you talk to GPs and other health professionals. There are enormous barriers to providing good quality treatment in the short time frames of people who aren't coming primarily for that issue. And before you think that Australian GPs are a problem, let me say this is a similar issue whether you're looking at paediatricians, secondary level care, tertiary care in hospitals. Whether you're looking in Australia or the US or the UK, this is absolutely normal experience. There are many challenges to actually providing good quality treatment. We have a 21st century health problem with overstretched health systems, and we often have undertrained or poorly trained health professionals who don't necessarily have the time or don't know where to refer people to. So we've reflected on how can our health systems respond to this, and one of the ways to think about using the chronic disease care pyramid. Let me tell you about this. This is an approach that's used for lots of other non-communicable diseases, and I've been encouraging people to think about this in terms of obesity. So you have this underpinning of primary prevention and health promotion. Can we stop people having this problem in the first place? I'm going to talk briefly about that next. And then you have this pyramid of care with the vast majority of people with problems like obesity being managed in the community, often self-care. There's a group who have more significant illness, level 2, who need to be managed in secondary level care facilities, need to have access to good quality allied health programs and so on. And there's a group at the top who need case management with highly sophisticated, really experienced groups of individuals. And there's a group who need bariatric surgery. And all of these need to come together in a coordinated approach with well-trained individuals, health professionals. Now, one of the challenges is that all of this is a bit still not quite together. One of the great things over the last couple of years has been working with my New South Wales Ministry of Health colleagues as we start to look at how we can fill in these gaps across the state, how we can train our individuals to do that. And that's been a tremendous approach. I can answer questions about that later. And now I want to come to talk about the final issue, which is about how can we prevent it happening in the first place. In that WHO approach to how they deal it, they highlighted the need for early childhood approaches to looking at diet and physical activity. And they actually quoted the study I'm going to be looking at that's been a world leader in influencing WHO's approach to thinking about these issues. Now, why would we be interested? 1 in 5 children are already affected at the time they enter kindergarten. So 1 in 4 overall, 1 in 5 already affected by overweight and obesity. If we wait to actually intervene in school settings, it's too late. And we know that what children eat and their levels of activity, even early on in life, are set in train and influence later weight status. So the Healthy Beginnings trial came out of that. Lee Ming Wen and colleagues from Sydney Local Health District are here, and Lee Ming led this as part of his PhD studies. Home visiting interventions can be profoundly effective for disadvantaged children, and we wondered if they could be useful in looking at obesity. So in southwestern Sydney, Liverpool, Campbelltown antenatal clinics, we recruited new mothers to this study, and we looked at the effect of a moderately intensive home visiting program, once before the end of pregnancy, 5 times in the first year after the baby was born, and twice in the second year. What could that effect have on weight outcomes? And there were some key intervention messages: promoting breastfeeding, healthy, active family, oriented towards the mother, trying to normalise healthy eating and activity for that child and that family. Well, what did we find? Well, there was an increase in breastfeeding. Yay. There was improvements in various aspects of infant feeding. Tremendous, both at 12 months and at 24 months. And indeed, the mothers themselves had improvements in what they were eating and their levels of physical activity. But our primary outcome of interest? Yes, we showed a decrease in BMI at age 2 years. This was the first study to do this internationally. If you look at the red bar, at the blue bar here, you can see the results from the children who didn't receive the intervention. This is looking at their BMI, and then you can see those in red who received the intervention. And the bit that's coloured is the equivalent to overweight or obesity. And what we did was that we shifted that BMI distribution to the left. Everybody's BMI went a little bit to the left. Still not quite the healthiest we wanted, but less unhealthy than before. We basically showed that there was a decrease in prevalence of overweight and obesity from about 18% to 15% in those kids whose mothers had received the intervention. We thought, fantastic. We wrote this up, there were editorials about it. We thought this was amazing. This is the first trial to prevent obesity in early childhood. But then we asked the question, always a bit challenging, does it persist? So we then followed up the children and young children and the families to age 5 years, but we didn't do anything further. All we did was measure them. So what did we find? Well, here's the BMI at 2, at 3.5 and 5 years. Now, first of all, you're saying, oh, it's dropping. I just want to reassure you, BMI naturally drops over this age group. So this is the control group of kids, the kids whose families didn't receive it. What about the kids who did? Oh, you say, I can see it too, there's a difference. But at 3.5 and 5, I can't see a difference at all. And no matter how much we tortured the statistician, we couldn't find any differences. We couldn't find a difference in anything. And we don't really torture statisticians. There were no differences between the groups. And this raises all sorts of interesting issues, apart from some heartache, but it's allowed us to reflect a lot on what needs to be done. Was our home visiting intervention originally effective because it was delivered in a disadvantaged area on the background of relatively few well childhood services? And we think that's important. And so we feel that the more intensive interventions are needed for more vulnerable families. And in fact, at Sydney Local Health District at the moment and elsewhere, there is studies undergoing looking at supporting particularly vulnerable families with more intense home visiting, including around these sorts of issues. But then we think, but the effects waned. And we reflect, is that because these children are leaving there, interacting more with the broader environment? We were doing nothing about the broader obesity-conducive environment in which children all over the country and in Sydney grow up. And we weren't addressing that all, and we feel that we must address this in order for any early interventions to be sustained long term. So we think that there needs to be a suite of interventions acting at every developmental stage across the life course. And here you can see pregnancy, infancy, through adolescence, young adulthoods, families, the workforce, midlife. You need interventions happening at all stages, and it will look somewhat different wherever you are. But we can't just think that intervening in early childhood or intervening in school is going to make the difference. And you certainly can't just set and forget. We're dealing with a very active and ever-changing obesity-conducive environment, and we are all responding physiologically to it. Now, it just so happened that there were a number of other trials occurring in Australia and New Zealand at that time, and we met up at a dinner at a conference and agreed to work together on this, and that has led to the Early Prevention of Obesity in Childhood collaboration, the EPOC collaboration. We've agreed to share our data from all these different trials. We've had funding from NHMRC and other areas. We think, well, if we combined our data, we're dealing with a sample size of 2,000 kids. That's more than anybody in the world is doing. And so far we've shown that, yes, when we combine the sorts of studies that we're doing, slightly different types of interventions, you can get improvements in weight status at 18 to 24 months of age. There can be a longer duration of breastfeeding. TV viewing time can come down at 2 years, and undesirable feeding practices can be improved. So great. And we're continuing to work with that. And so good was that collaboration that we've now been established as an NHMRC Centre of Research Excellence in the early prevention of obesity in childhood. We've got people from Australia, New Zealand and the UK working this. And this is the first internationally. This is our website, and we have a great domain name, www.earlychildhoodobesity.com. Really easy to remember. And I want to just say, this is the power of coming together with these incredible other people. We have several streams of work. We're looking at analysing existing intervention trials. We're bringing in trials from around the world to be able to look at what are the effective elements of this. We've got health economists looking at economic evaluations. I've showed you some of that data earlier on. We're looking at how easy it can be to measure some of these behaviours. And most importantly, at the centre is, can we translate the evidence into policy and practice? An example at the moment is that we are working in Sydney Local Health District and with some other health districts to look at whether SMS and phone coaching support can help new mothers in this process. But as I finish my last couple of slides, let's just think about the world in which young people live. This is it. Children are hugely assailed by food marketing, this array of often less than healthy foods. They have sedentary lifestyles. They keep inside. The world is dramatically different from that of 20, 50, 100 years ago. And are we tackling these influences which can have a profound influence on obesity? That's beyond the focus of my talk here, but you might want to ask questions. As I finish, I want to acknowledge the amazing people with whom I worked at the Children's Hospital Westmead and the University of Sydney in particular, as well as the EPOC CRE. I've had amazing students, postdocs and clinical and research colleagues here and around the world. And I want to say thank you.
And above all, we want to say thank you to you, because if you hadn't taken the leadership, so much of this wouldn't have happened. And it's so inspiring to know that something's been done about this problem. We've got time for a few questions, so... yes, we're going to have a few... Don. Was it Don? Yeah,
so we're getting incidental physical activity from the people with the microphones. Excellent.
Donald Hector, Royal Society of New South Wales. You just touched on the issue that I'd like to ask a question about in your last slide. Why is government policy so lacking in this, and why are public health officials so reluctant to do anything about things such as, if I take a walk through my local supermarket, half the shelves are loaded up with soft drinks full of sugar and poor quality fats that in many countries are banned, such as palm oil and cottonseed oil, trans fats. If I look at the dollar per calorie, the cost of these junk foods is much lower than the fruit and vegetable section. I'm sort of reminded of the tobacco industry. 40 years ago, everyone smoked, tobacco was marketed, government policy taxed tobacco products into the ground, brought in plain paper packaging. Why don't we do the same with health?
Well, I'm clearly very much in support of the comments that you're making. I think we've seen in New South Wales tremendous leadership at a state level recently. With the tackling childhood obesity being one of the premier's priorities, and really seeing leadership within what New South Wales Health is able to do, including changing things like health facility types of food and beverage vending and things like that. We do know, but we live in a multi-level government, and there's huge importance of federal government in this. If we want to regulate food marketing directed towards children, have a look at national food policy, if we want to look at issues such as taxes on unhealthy foods. I and my colleagues, and with whom I work at the University of Sydney and elsewhere, are very much in favour of things such as sugar taxes, but that needs real leadership at a federal level to make that happen. Now, I think it's our voices as individuals and as groups need to be put into this, because I think there's very strong science for that. We can see leadership in Mexico, which has gone to a soda tax and has seen, because it's had very high prevalence rates of obesity, very high prevalence rates of soda consumption, and there's been a dramatic decrease in soft drink intake and an increase in water intake over the 2 or 3 years since that actually occurred. And I understand there's also improvements in dental caries rates as well. So I completely agree with you. We need leadership at every level of government. It's not just enough for there to be leadership within the Ministry of Health in New South Wales. We need leadership much more broadly. And we as citizens and people in industry and beyond need to be advocating for this. We're dealing with very, very strong players, marketers, advertisers. These big companies are incredibly powerful.
Over there.
Hi, I'm not a doctor and I'm not in allied health, but I heard you say that doctors are poorly trained in this area, and I could not understand that. And by the way, I'm obese as well.
Well,
and I know that it's a simple equation. If your calorific input is more than your consumption, you're going to get fat. But my thing was that it is like saying crime in society is increasing and people end up in prisons. Therefore, it is the fault of the prison officials that they did not educate the general public and let them commit crime.
So if I could comment on a few of those things, can I just say obesity sort of crept up on us relatively slowly, so that when I spent my 6 years as a medical student at the university, I had one 1-hour lecture on obesity. As it so happens, it was from a wonderful person called Ian Caterson, who's now president of the World Obesity Federation, one of the amazing people at the University of Sydney. So most people were poorly trained. That is changing, and we're now seeing much better training of a whole range of allied health professionals, nurses and doctors at undergraduate level. One of the things, one of the comments about the leadership at New South Wales Ministry of Health is that we've now got what I think is the world first approach to online learning for all sorts of health professionals. So we've developed and evaluated short e-learning modules suitable for any health professional who sees a child, short ones, so enable them to raise the conversation, be able to give simple, brief advice that's high quality and evidence-based. Now, as far as we know, that free online learning and the heap of resources that go with that are the first internationally being made available to any health professional easily. They were launched earlier this year. So, we're having steps, they're starting to happen. It's a little bit like we now realise there's this big issue, but we've got to turn things around. We've got to educate large numbers of health professionals internationally so they feel competent. Can I just come back to the issue? I think everybody here would realise that, given that a half of women suffer from overweight and obesity and 2/3 of men in Australia likewise suffer from it. We know this isn't easy. We do know that eating and activity are really important, but turning that round is very difficult in the context of a highly obesity-conducive environment, particularly one that's very conducive to obesity if you live in socially disadvantaged areas. It's one of the reasons we need good treatment. We need health professionals who are trained, and we need to have good treatment. But we also need to address those issues that were raised earlier about the upstream drivers of obesity. It's not easy. I actually tell my students, whatever you do, don't say just eat less and exercise more, because it's profoundly difficult for people to be able to change that. Most of the drivers of the food we consume and our physical activity environments lie outside the ability of an individual or family or even Minister of Health to change. We need really whole-of-society approaches to getting us back to an environment where we have walkable, safe, healthy environments where kids can play and not get run over, and where we have healthy foods that are available and where the cheap foods aren't essentially the unhealthy foods. That's going to need huge changes.
Thank you. Over there and then a couple here.
I have a question about exercise, because a person can be obese and yet healthy. What are the measures that are being taken at the moment from a research approach to investigate that specific aspect of things and the significance of exercise and active lifestyle?
So I haven't gone into all. So our group and our broader groups have actually been really interested. Have been really interested in physical activity. Physical activity is one of the things we know over the last few decades, that there's been a decrease in incident of levels of moderate to vigorous physical activity and in active transport, walking to and from school, for example, and in incidental physical activity. We've seen this rise in screen time that's displaced lots of other activities. So there's almost nothing bad about increasing physical activity for any illness or any, for health. It's just all good. So in fact, studies we've done have shown that a whole range of strategies to try to improve physical activity through group programs after school in regional, in regional areas, to having gym programs. The RESIST trial included involving fitness first programs for these young people. So we have a whole range of strategies trying to improve that. Clinically, there's a whole range of other strategies such as self-monitoring. I do want to pick you up on that. While physical activity can improve a whole lot of cardiometabolic complications, in fact, if you do have moderate to severe obesity, you still have health complications. Physical activity can moderate that to some extent, but your risk factors don't quite come down. Okay. No, okay. So it's not, but any form of physical activity certainly moderates things. Clinically, we encourage that all the time, but the factors making young people sit are profound. And if you are a big young person, it can be very difficult to start getting moving. You may feel large. You may feel very vulnerable. I've had children say to me, we only walk after hours so that people don't see us too much. People laugh at me. Young people don't want to get into their swimming costumes. They don't want to be seen to be physically active because they're very aware of their body image. So there's lots of challenges to being active.
Thank you. Yes, there's quite a few questions, so we'll go Ruth,
briefly.
then the one, and then I think we'd better finish. Sorry.
I'm GP on the lower North Shore, so I'm in a higher socioeconomic group.
I think Mosman has the lowest prevalence of obesity in Australia.
I'm not in Mosman.
Not far off.
I've always been acutely aware of weight issues, to the point where some of my family accuse me of being fattest. And I agree with the gentleman behind here who said it's like asking the prison officers to deal with the increase in crime. My experience has been that patients do not want me to discuss their child's overweight. They get aggressive. Interestingly, they even say, "Not in front of him, I don't want him to become anorexic." And we are not trained in this. Dietitians are trained in weight reduction. There is no free access to dietitians, and we're left struggling, doing our best, giving a little bit of a... And yes, we can identify the problem, but even in our area, it's really tricky. So I guess the message is, please could we have some free access to dietitians and some general government support for all the factors that you've raised, but it's not general practice that has to change it.
Thank you for raising those issues. There are some important issues there. The training program that I talked about does go into some support to help any nurses, allied health and doctors think about how they raise these issues with families, trying to use approaches that might involve families, but it is a challenging thing to talk about. I can assure you that good quality interventions to treat young people with obesity, either at a clinical level or at a population level, have not been shown to increase eating disorders. In fact, have been shown to improve disordered eating. But the issue you point about the need for good quality allied health, not just dietitians, but exercise physiologists, physios, clinical psychologists, as well as experienced nurses. We really need those available to help people. So I agree with you. Nevertheless, GPs are the backbone of our health system, and so part of the work we've been doing is trying to work out how we can support GPs to be able to do this challenging job as well. But I completely agree with you about the need to improve and increase the workforce that is competent in dealing with this issue.
And one last question.
Hi there. Thank you for your fantastic talk. I would like to ask you about the ethical question of individual responsibility versus what would be the most effective way, which is the combination with the upstream, top-down approach. And it's not just health; it kind of seeps into political views in general. But yeah, what can we do about this shifting idea of individual responsibility about health?
One of the slides I took out addressed this particular issue. Pekka Pushka, who was very senior in WHO and who was a senior physician, public health physician, who was responsible for decreasing Finland's, one of the people involved in decreasing Finland's world's highest cardiovascular disease death rate statistics, had this concept of dual responsibility. So if you imagine a steep hill, a gradient, with this poor person pushing this boulder, this poor Sisyphus, pushing this boulder of healthy eating, healthy weight, healthy physical activity, but the steep gradient makes it very difficult. That steep gradient is the environmental gradient, and that work that individual doing is their personal responsibility. If we bring that gradient down, it is much easier to move that boulder of physical activity, healthy eating and healthy weight. So yes, of course, individual families and people have responsibilities for food and physical activity, but if they live in environments that make it almost impossible to be physically active in a healthy way or to make healthy food choices, it's very, very difficult. So my personal view is that as a community we need to support children, young people and families to have an environments which enable healthy activity, healthy eating. So we absolutely need to have those upstream approaches. Yes, we need to support people at the downstream level, but if we're not dealing with the upstream issue, which is what has gone wrong, then we're not dealing with anything. It's not as if in the last 20 years people decided, I'm just going to sit down, not eat well, and be physically inactive and be stressed. That is not what people have done. People have responded physiologically to what is essentially a pathological environment. And we've had all the results that I've talked about today as a result.
Thank you. And we'd better stop there and say, and on behalf of all of us here and on behalf of New South Wales, Louise, a little present and acknowledgement of all you've done.
Thank you very much. Thank you, Mary.
I'll just make a couple of announcements. This talk is deliberately done for this time because we're now into the Sydney Science Festival, and I really wanted to illustrate that science can make a tremendous difference in our community. But if you've got kids, grandkids, and you want to go involved in active family activity that's also very good for the brain, there's a whole range of wonderful activities on. You missed me and Princess launching things yesterday. Princess is my friend, the black-headed python. But you can, on the little booklets you've got in the chairs, you can find lots of other wonderful things to do right across New South Wales, with 200 events in Sydney and another 400 around the state. And then there's a little bit of a break till we have our next breakfast, and that one's on The Hobbit. And that'll be Richard Roberts from Wollongong, the head of the new Centre of Excellence on, and I'll just refer to it, The Hobbit, so you look it up. It'll be very exciting. And then we have 3 seminars in a row quickly because, as I mentioned, we're inserting an extra one. And Troy, is it what, the 5th of November, is it? Yeah. So on the 5th of November, we have Peter Svensson, who's one of the leading innovation thinkers from Sweden coming, headed a think tank, now works at Vinova. And it was he who introduced me to Nick Kay, one of our previous speakers this year, who's the head of the Sydney School of Entrepreneurship. So we're having a seminar, breakfast seminar from Peter on the 5th of November, and of course that's a couple of weeks after we hear from Richard Roberts on the 18th of October. So looking forward to seeing you then, and in the meantime, enjoy Science Week. Thank you.